Good afternoon. This is the last lecture for this module. In this lecture, I will be describing the new approaches to detect genetic abnormalities, as well as the important aspects of genetic counseling in reproductive genetics. The new approaches in prenatal testing and screening is non-invasive genetic screening or testing, abbreviated as NIGS or NIPT, and pre-implantation genetic diagnosis. The risk for fetal loss has made parents very often decide not to do any invasive testing. And since the 1960s, attempts have been made to make a diagnosis by obtaining a sample of maternal blood. In previous studies, attempts were made to isolate fetal cells in the maternal circulation, but that didn't seem to be successful. Further tests and research has confirmed that short fragments of cell-free DNA, both maternal and fetal, are present in the maternal blood. The fetal DNA arises from placental cells undergoing apoptosis, and the maternal DNA arises from occasional degradation of the maternal cells, also through apoptosis, but also necrosis. Only 10 to 50% of the cell-free DNA in the maternal circulation between 10 and 20 weeks gestation is from fetal origin. The easiest sequences to identify is from paternal origin, including the Y chromosome sequences. It is therefore now possible to do non-invasive fetal sexing with a specificity of about 90% and a sensitivity of about 98%. Even paternal sequences for genetic conditions such as achondroplasia has been detected in maternal blood. Fetal aneuploidy screening can now be done by massive parallel DNA sequencing, where fetal DNA can be distinguished from maternal DNA with a sensitivity and a specificity of about 99%. Pre-implantation genetic diagnosis or testing is very challenging, as only a single cell is used to evaluate the oocyte or the embryo. After fertilization, blastomeres is removed for analysis and allowed to divide. This is achieved where the mother's ovaries are stimulated to produce many ova. They are removed and fertilized with sperm. The cells are then allowed to reach 6 to 10 cell stage, where after a needle is inserted into the embryo and only one cell removed. The rest of the embryo can develop normally despite the loss of one cell. Only unaffected embryos will be implanted into the uterus. None of these procedures, and actually no genetic testing, should be done without genetic counseling. The two definitions for genetic counseling is as such. Harper, who is one of the fathers of genetic counseling, said, "It's a process by which parents or relatives at risk of a disorder that may be hereditary are advised of the consequences of the disorder, the probability of developing or transmitting it, and of ways in which it may be prevented, avoided, or ameliorated." That means to make it better. Kelly described it as an educational process that seeks to assist affected or at-risk individuals to understand the nature of the genetic disorder, a transmission, therefore the inheritance patterns, and the option open to them in the management of it and in family planning. In the case of reproductive genetic counseling, the counseling will deal with risk for the fetus to be affected. Is it low? Is it high? The nature and possible consequences of the specific problem under question. Background information will therefore be important, and you need to know about the condition. And if not, you need to read up. The procedure needs to be done, and the risk and limitations of the procedure should be explained. This might be only a screening test or invasive testing. The turnaround time for the results and the possibility that the tests need to be repeated is always important to discuss. There is always a chance for inconclusive results that might need clarification with further tests and consultations. And lastly, despite the result, it might not be definitive and not clarify the answer. Genetic counseling will entitle the taking of a history, including a full family history. A family pedigree will be necessary from where genetic risk can be calculated. In some cases, we will use arbitrary risk depending on the condition. Parents will be advised to them and other family members about the risk, and particularly in the reproductive risk for that specific pregnancy or for an affected child in general. The test will be offered, but the decision will be the parents if they want to go ahead with the test and or not, and the risk for the procedures and tests should be outlined. The various options thereafter to reduce the risk should be discussed, and possible treatment could also be discussed in this session. The choice will be the parents if they want to do the test or not, and the counsellor should only provide the necessary information to help them in making a decision rather than direct them to a decision. This is also important in the case of their decision of continuing or terminating the pregnancy. This is named non-directive genetic counseling. In the case of a prenatal diagnosis of a serious condition, it is very important to remember that there is no implied obligation to the parents to terminate a pregnancy in the event of an abnormality being detected. And the decision is solely the parents. We are just here to help and not to judge. In medicine, there are 4 ethical principles that we need to uphold: autonomy, beneficence, non-maleficence, and justice. Autonomy means a person and their privacy should be respected. The person can make their own choice after they have received the information on their own management, and in this case, if they want to have a test or how they want to react to the tests. In this case, consent is very important, and it should be informed consent, not just signing a form. In the case of beneficence, the professional, the doctor, or in this case a counsellor, wants to do good and act in the best interest of the person. You might not agree, but it must be the best interest of the person no matter what they decide. Non-maleficence means seeking overall not to do harm. It is thus important not to leave the patient in a worse condition after the test than before the test or treatment. And lastly, justice, which means that there should be fairness in the allocation of resources available and the equity of access to medical care, as well as the opportunity for all these tests. I'm not always sure in South Africa, where there are two medical care systems available, that justice always prevails. Prenatal diagnosis is challenging and there are always obstacles. Is the test available in South Africa, or if abroad, can it be done? I always get so anxious when people come to me and request testing while they are already pregnant. The planning of these tests are very important. You will also need to know the different indications for testing and why it is sometimes difficult to interpret the results. We sit with people with all different cultures, religions, and different ethical values in South Africa, and this needs to be kept in mind when counseling for these very difficult conditions. I always tell my patients that this decision, if they should continue with the pregnancy or not, might be the most difficult decision that they will ever make in their lives. I therefore don't think that this is a decision that person can make whilst not being in that specific situation. And I therefore can't think that any one of you can for sure say which decision you would make if you're in this situation when your baby has a serious disorder and you need to decide if you are continuing with the pregnancy or not. We are all here to help each other, and whilst most babies are completely normal, there will be a percentage who will have serious defects. But we hope that each child will be normal and live a normal life. Thank you very much for listening. I will be available in email if there's any questions or comments.